So good morning, everybody. Thanks for turning up. So I'm very happy to have Cara Thomson along today to talk to us about human factors and safety. She's a consultant anaesthetist and has taught a lot on this subject, as well as it's a subject that's very familiar to anesthetics, where they've improved the safety of anesthetics so much over the last couple of decades using systems and processes to help improve safety, which is the subject of human factors. Cara is also running a fantastic program called Network Z, which is a simulation program designed to look at human factors within the operating space and help teams understand how to control for these and improve the safety. So very much aligned to what we're going to be talking today, and I'm very glad that Cara has given up her time. So thank you very much, Cara, and I'll hand over to you now.
All right, thank you. Nice to see everybody here this morning, and I'll get on and try and start this presentation. I'd like to thank James for the opportunity as well to do this. This sounds like a really interesting program, and I'm keen to find out a bit more about it. So we'll just check that first of all that I can get this shared. Sorry. Technical problems already. Sorry, just 1 moment.
It's okay.
Okay. There we go. How's that?
Yep, we can see that.
Great. So today's topic, I guess, to start with, is the science of human factors. And here we go. So the aims of today is here: explain how human factors principles apply to healthcare, describe how changes to processes can mitigate the effects of factors and contribute to error, right? Define some concepts: simplification, standardization, constraints, forcing functions, and redundancies, and discuss risks and benefits of using technology to improve safety. So there'll be some of the goals will be activities that you will look at later. And the outline of the lecture today, again, understanding the science of human factors, having a look at designing principles to reduce human error, and risks and rewards of technology. Okay. So why does all of this matter? Well, healthcare workers who do not understand basics of human factors are like infection control professionals who don't understand microbiology. So if you don't understand why you're doing something or why it matters, it's really hard to make it work properly. And being aware of common types of cognitive errors can help clinicians recognize them and avoid them. And it's certainly when we do this, it's part of our anesthetic training as well, that we understand errors and delve into why they happen and how to improve things. Oops, sorry. Now, James, just briefly, I haven't got the chat function up on my screen again, so I'm not sure why that's. In case people are wanting to chat, feel free to do that.
If you want to open up your chat window, it's the 3 dots on Zoom. It says more. And if you click on that, it brings up a menu, and there's a chat menu if you can find it. Otherwise, I'll keep an eye on the chat and I'll let you know.
Right, here it is. It just disappeared. Great. Okay. So types of errors. Now, there's the definition tree here, which is definitely really helpful, but it is a bit confusing to understand what everything actually means. The first thing is to define what an error actually is. So an error is a failure to carry out a planned action as intended, or an application of an incorrect plan. So an error is not just a mistake. There are other things that can happen. So two aspects: action does not go as intended, or action goes as intended, but it's wrong. So that's a mistake. A slip is an action that does not go as intended, but it's an observable error of execution. And in my definition, it results from the failure in execution of an action, whether or not the plan behind it was adequate to reach its objective. So something is misdirected. All right. And a lapse is an unobservable or mental error of execution. So it might only be apparent to the person who experiences them, such as forgetting to administer something, or forgetting to administer antibiotic prophylaxis prior to tourniquet inflation. That would be an example in an anaesthetic world. So essentially, or often forgetting something, a lapse in memory. And a mistake, an error in decision making or incorrect planning. It kind of happens when the plan isn't inadequate. Right? The operator is aware of a problem and begins to use rules and knowledge to solve it. But when the knowledge or rules are lacking, that's when the error occurs. And mistakes, so they can be rule-based, so error in applying knowledge correctly, or knowledge-based, and that's when the error is stemming from a lack of knowledge. All right. And the other aspect that's really important to think about in all of this is the two types of mental processes. So they're automatic thinking or controlled thinking. And these also are often described as systems 1 or systems 2 thinking, if you've looked that up in any reading. So automatic thinking or systems 1, so it's rapid and effortless. You do it without thinking. It's something that you're used to and you know how to do it, like riding a bike, driving a car. And it's prone to errors of execution, as in slips or lapses. You forget to do something that you had intended to do or needed to do, but because it's something that you do every day. Controlled thinking is conscious and slow and deliberate. So it's solving a problem or making a tough decision. And it's prone to errors of planning. So that's the mistake, where it could be a lack of knowledge not allowing you to get to the bottom of the problem. Hope that all makes sense. Cool. So is there anything in these pictures that you wouldn't drink? There's a whole variety of things here.
Can people on the chat maybe write the name of the bottle that they would not drink? Takes a couple of minutes for the chat to activate.
So everyone's getting the picture in there, so that's great.
Fiona says Thai doesn't look too tasty.
No.
Not
everything else on that picture seems to look pretty tasty.
Yeah.
Someone's picked up something else. So on that, we'll move to the next slide. Again, there are actually two things on this you wouldn't drink. So the Tide and the Fabuloso baking soda. So Mandy has picked that up, which is really good spotting. Yeah. So what is it that in these pictures make it obvious that you don't want to drink it? So first of all, it's the design of the product. It's the name of the product, the type of bottle and the type of lid. But interestingly enough, the Fabuloso baking soda looks very similar to a whole lot of other things that we would drink regularly, juices and the like. And I think that's really important when you're looking at product design and avoiding, for example, children drinking things that they shouldn't because they haven't looked at it or read it and don't understand. Right. So continuing on with sort of the thinking processes, think about cognitive errors. As we think, we use heuristics or mental shortcuts to simplify processes or thought processes based on patterns and past experiences. We're able to assess the situation quickly, but we can miss things. So these are some examples listed on the slide, but I like to think so from my own experience or my own examples in anaesthetics, it might be something that we used to, something we see all the time, we take a shortcut, but it's not right. For example, assuming hypotension is due to the administration of anaesthetic at the start of a case, or assuming hypertension is due to pain, but not anything else. So it's all right to have these shortcuts and processes. They can speed up diagnosis and management, but you really need to think outside the box at all times as well. So what factors make these errors more likely to occur? Well, what I want you to do is imagine these scenarios and think about any automatic and controlled thinking involved in these tasks. And I was wondering if anyone had anything to add to the chat or voice to see any examples they can think of. And that's all right if you don't, that's fine too. So some examples, you know, we've heard a lot about lately about cognitive bias. That's something that influences what makes errors likely to occur. That's an example. You've also got other things like fatigue. Here's my other list of ideas.
I've got an idea. So, like nurse delivering treatment, she's using picking the drugs out the cabinet, and the boxes look very similar, and she could easily pick up the wrong box.
That's an excellent example, and it's something that we also think a lot about in anaesthetics, as we're always getting out drugs, drawing them up, and sometimes in a hurry as well. A pharmacist filling an order. An example of that could be on a handwritten script that something's difficult to read. That's an example. Person diagnosing a patient. Lack of knowledge could be an example there as well.
Yep. Or again, another one would be going to the wrong patient on the ward. That's that's actually happens from time to time. It's quite embarrassing.
Yeah. Great.
Personally, I feel like, especially if there's any particular routine step that suddenly deviates away from the previous pattern, it seems to be more prone to make mistakes too. So, for example, if we been prescribing the same medication over and over again for a particular patient, but then now this patient that is, for example, allergic or anaphylactic to common medicine, that because of the type 1 thinking, we generally keep writing the same thing or do the same, prescribing the same medication without thinking through whether there is any contraindications. And sometimes it can happen without us realizing it.
Yeah, that's absolutely right. That's a really good example, and a very similar thing to that is something that we prescribe all the time, but the dose needs to be changed for a particular reason, and we haven't been aware of that. So that's also an example. Yeah. And Jen has written to everyone here, interruptions during the process of task. That's vital in all of these activities, but particularly the either preparing of drugs or making them up. And distraction interruptions is also from Angela as well. Thanks. Great. So I started bringing up some of these things, but we can categorize these factors into internal factors, external factors, or cognitive bias. And internal factors can be your psychological or physiological state. So we all talk about fatigue, stress, hunger, illness, attitude, and memory. And I know that for myself, if I'm hungry during a long case, I get distracted. I'm distracted by the thought that I'm hungry. I'm not able to focus as much on my work. And in anaesthetics, our team is really supportive of that feature, I guess, or factor, that we do need a break to be able to maintain our concentration and vigilance for a long case. Which I think is one of the factors. One of the great things about anaesthetics is that we do have that support and mutual understanding of those needs. External factors, we've talked about some of these as well as far as distractions go, but work scheduling, shift patterns, all those factors are vital. Noise, if you're trying to do lots of things in a noisy environment, it's really difficult. If you're too hot or too cold in your work, it's a constant debate in theatre, isn't it, James? Yeah. Things like procedures and language barriers are definitely important, and it's actually not something that we deal with very much down south here in Dunedin. I spent a year working in Auckland a couple of years ago on my simulation fellowship, and we dealt with interpreters every single day up there. It's quite a different environment, and it definitely changes on how you need to act and the time it takes to perform a task. So that's when errors can occur as well. You might be more likely to miss things, speed things up, or things will get misinterpreted by the interpreter as well. And cognitive biases, I think this is really critical, and it's certainly an area I need to widen my understanding of a lot, but it's worth considering your own cognitive biases and what you do. Again, it's often related to your education and how you've grown up, but you can, first of all, think about different people in different ways, but you can also just assume that you know what an error is due to, so you attribute it wrongly when you haven't thought outside the box.
Yesterday, I found out for the first time my regular anaesthetist has a baking roster, or is part of the baking roster on the team, and now it's not just an exercise in making sure that everybody brings in nice cakes. It's also an exercise in safety and human factors.
Yes, very good. Okay. So how can we prevent errors? Vigilance and hard work can be effective to a point, but we can not sustain performance merely by trying hard and paying attention. So this is where human factors comes in. And human factors striving to understand how people perform under different circumstances in order to build safer systems. And I mean, who defines human factors as the study of the interrelationship between humans, the tools and equipment they use in the workplace and the environment in which they work? So human factors is not just about humans, it's about everything that we work with and the place that we work. So we can use all these principles to help improve our systems. So anaesthetics, as James mentioned, is used a lot in this discussion of human factors. In the past 20 years, patient deaths from anaesthetics have declined from 1 in 5,000 to 1 in 200,000 plus. So much so that many of us in anaesthetics haven't experienced a death related to the anaesthesia that we give. So key changes, standardizing valves, so standardizing the way the machines work. Even though there's different brands, things that used to turn in different directions now are forced to turn in the same direction. It's not 100% true, but that helps to make sure that when we go to a different place or use a different machine, we know the basics of how it works. Avoiding reliance on memory through checklists. In the old days, and it was the same for medicine in general, where we are expected to know and understand everything as far as learn it from rote memory, that's no longer the case. It's much more important to understand the process of diagnosis, for example, and how to find that information rather than memorizing everything. And we use a whole variety of checklists, particularly for emergencies, to help us make sure that we're not missing anything. and there's an acceptance that that's the way that you do it now. So for example, we have an anaphylaxis kit, and in that kit contains a whole lot of cards to do with basic management, differential diagnosis, problems if that's not, none of that stuff is working, what to think about. And promoting teamwork by encouraging nurses and others to speak up. The surgical, sorry, the surgical safety checklist is really, I think, one of the key things in this example of changing systems. That is now designed in a way that the whole team participates and the whole team is asked to speak up. So that's just one way of encouraging teamwork, and certainly I experienced that in theatre the other day when I was anaesthetising a child, and a nurse spoke up about something when we were halfway through the case, and it really did alter the management or made sure that we weren't missing anything important. And the Networks simulation program is another example of promoting teamwork, where we, as a team, we're practicing big in-theatre emergencies and getting used to people having different roles and saying what's important. So training is really important in this aspect as well. I think factors that we sort of emphasise in Networks, to promote teamwork, we need a mutual respect and trust of all of the individuals in the theatre, amongst other things. All right. So there are a whole lot of strategies to prevent error, and it's really important to think about different ways that you can improve things. And some of these certainly mentioned just before, but they happen in lots of things. So I'll leave the list there, but if anyone can think of any examples, please write them in the chat. One of the interesting ideas are use of forcing functions. Now that's when things happen in an order to help you not forget things. And if you think about an ATM has a forcing function. Before you can take your money, you have to take your card. So they make sure that you don't leave your card behind. And there's a lot of processes and things that have gone into the thought about that. Promote effective team functioning. We've talked about training, networks, communication strategies. That's great. Thanks, Angela. So interprofessional practice, learning from, with, and about each other. So that's working as a team, training together, because we often train in our silos, and we often should train together as well. Other ideas. Avoiding reliance on memory. We talked about checklists. And one of the other examples from an anaesthetic perspective is, for example, our drug trolleys in theatre. In every theatre now, they're all exactly the same. So when we go into a theatre, we know exactly where things are from an anaesthetic perspective. When we go into help or a different case, or we get stressed and we're not in our usual place of work, then we have a pretty good ability to get what we need in a hurry. Yeah, any other examples people have to add, or James?
One thing that struck me with you was that the fact that people were trying to work together and training together and stuff like that. And I think some of that comes from the work in the airline industry, where they found that cockpit errors were more common when there was a much higher hierarchy gradient.
Yes.
So if there was a very senior pilot and a very junior co-pilot, the co-pilot would feel prevented in speaking up about errors, which may actually be important to flag up. So by trying to flatten the hierarchy within the theatre, that can help reduce errors. So one thing that a surgeon can do, such as me, is to try and use people's first names to make sure that they don't feel intimidated by any of the requests and instructions. So trying always to say please and thank you for things. These are very small things, but they actually improve the safety of the theatre.
Absolutely. And yeah, James is right. A lot of the anaesthetic crisis resource management principles have been delved from the airline service, although we're definitely trying to move away from that, because unfortunately our patients aren't like machines, and they don't behave in a specific or expected way often. But the principles are exactly the same, and we use a lot of videos from the airline industry in our training. Great. Right. So it's a little exercise now. We've got a couple of examples of strategies here, and then you've got to add, I guess, the principle behind it. So if you'd like to have a look at these examples, think about what the strategy is that matches this thing. So double checking someone's work. An example is that's the use of redundancy. So how would I better explain that, James? Sorry.
Sorry. Yeah, I think you explained that.
Is.
Double checking somebody's work
good.
is basically doing the same thing twice. And if something was wrong one time, then it will be hopefully right the second time.
Yeah, that's right. So we'll skip to the next one and you can have a look. So if everyone is thinking about this in their own way, it's good to go through each thing. So removing a step in a process can often be simplifying a task, making things easier, making sure that the process happens without other errors being skipped. So that's an example of simplification. A checklist or a policy or procedure, or I guess a procedure in a way, can also improve this by removing a step in the process. You've got a process to follow, I think, is the important thing there. So
yeah,
patterns,
I remember when we were designing all the processes around the COVID theatre, and there was a checklist of I can't believe it, how to put on PPE and how to take it off. And we looked at the steps, and there was about, I don't know, taking off PPE was about 25 different steps. So we ended up having one person there with a checklist telling the person what to do to take the PPE off. It was quite astounding.
That's definitely a really good example, and it isn't possible on a routine day for everyone to remember all of those 25 steps and in the correct order as well. And so having a checklist and having a double checker there as well makes those things, helps to prevent the error in the system, really. All right. So technology. It's often been heralded as a solution to mitigate and prevent human error. For example, barcoding, computerized prescribing order entry systems. MedChart is an example of an electronic drug prescribing system, and programmed intravenous infusion pumps. However, all of these systems still require humans to enter the information. So that's just a really important thing. And an example of barcoding in Auckland, they have a system where you barcode your drugs and you scan your drug in before you give it. Still has an element of human error attached to it. So, but technology has challenges as well, and things like that, like alert fatigue, so alarm fatigue, we will call it in theatre, where there's so many alarms going off that you stop listening to them altogether, or you turn them off if they're that annoying. Poor design features of technology and an over-reliance on technology. I think technology is really important, and it has improved the way we work in all of our healthcare systems, but we can't rely on it as the answer. Best practices. Design processes to be effective first, and then use technology to simplify and standardize. So again, with anything, you need to understand what it is that you're trying to achieve, and then work out the methods to achieve that. It needs to be tested in the real world. It needs to be tested by situations, by actual users. Because what we find is that if technology is introduced without testing, this leads to things like workarounds, where you just avoid doing certain things, or you make it up on the fly. And that's often a personal thing, and nobody understands the other workarounds when a new team comes to do that activity. So, like we just mentioned, users shouldn't be over-reliant on technology and still perform double checks when reasonable, and accepting that errors can still occur. Now, I wanted to mention around the testing, simulation is an example of a feature or a factor that can be used in testing technology. So when we say tested in the real world, so we design a new product, a new technique, a new process, we should test this before we actually bring it to use on patients. And we can do this with simulation, with the use of mannequins or processes to make sure that we're not, make sure that things actually work. And an example of using simulation again in this situation is testing systems in a new hospital. So when we build the new hospital, we should be going in before we bring patients in to make sure that we can run, for example, a resuscitation in that room. We can get access to all the equipment, we can get access to phones and the help that we need, and the whole process works. It's the same in an operating theatre where things should be tested. Have you got enough space? Can we get around? Can the anaesthetic team access the gases? Can the surgical team access the suction ports? All those things we need to actually test before we put people in that environment.
One thing I found out when I was last year working in Christchurch is that they have a simulation center that they built in a warehouse a couple miles away from the hospital. This has actually been lauded internationally as one of the best ways to design a new hospital. So in this warehouse, they mocked up what the layout of the ED department would be like in the new hospital. And then they got all the staff, quite a lot of the staff from the ED to come and actually run some ED scenarios in the new layout of the ED and find out all the problems. And then they changed everything around because they just were using boards and movable tables and trolleys and tried again with the new layout. And that way they found the best design before actually committing it to bricks and mortar.
Yeah, that's a really good technology, really good process to check on our technology. All right, so I think we're up to the video now. So James, did you want to share this so people can watch it?
Yep,
or...
I will take over and connect you up. Can you see that, Cara?
Yeah.
Great. Okay, so we'll play this video. It's about 5 minutes long.
Can't hear it, James.
Oh, hang on. Are you struggling to see is it jumping a lot?
You're speaking with your headphones on, and so it's only using your headphone audio, so we can't hear it.
All right. Yep. Yeah, okay. I need to change the setting. Hang on. Share computer sound. There we go. Can we hear that? Can you hear? Could you hear the music?
Yes, we could hear that.
Welcome. This is part 2 of our reliable design methodology. In part 1, we talked about why we have reliable processes and what we need to do to make them reliable. Now we're going to talk about the methodology and how you can begin to apply it in your processes. The first is to start small. That is, start with a subset of your population. We know that in all situations the same process won't work for every patient, so we have to figure out which ones work best and how do we apply them in the context of the care that we're delivering. We also have to design the process that is the easiest to work with. That is, we don't want to add complexity to what the caregivers are doing every day, so we're going to simplify that process, make it as easy as possible to do the right thing. And ultimately, by starting small, you can learn about what works well in that population, because if you can't get it right in that population, what makes you think you can get it right in the rest of the population? So learning will help you grow and spread your processes to other populations. What is a subset or a segment? It should be a group of patients that are easy to identify. It should have willing participants on the part of the healthcare providers who are willing to work with you to test new methodologies, to test the way you want to design the process to make it more reliable. You can learn from that subset so that you can continue to expand and spread your work. And the subset has to have enough volume that you are able to test daily or every other day. And what we mean by that is that if you are not able to test daily and you can only test once a week, you can only learn once a week. If you run your tests daily, every other day, or even multiple times in the same day, each one of those is an opportunity to learn, and so you can move more quickly in your improvement processes. An example could be patients in one ICU, or it could be just Dr. Smith's patients, for example. Or it could be just patients in one clinic of a large clinic setting. Or it could be just male patients over 65 who are coming in for a particular screening. Those are all examples. Now your subset you have to examine, because if it's too large, then you need to narrow it down a little bit. If your subset crosses many areas of care, that is many clinics or many units, many wards, then that's going to be a challenge too, because each unit has its own culture and its own challenges, so you want to try to limit it to just one area. But just remember that it has to be volume large enough that you can test daily or at least every other day. The next step is to visualize the steps in your process. We ask you to draw a flow diagram of 3 to 5 boxes, and no more than that. Some of you may be familiar with lean methodology or others that ask you to draw this very complex driver diagram, and there's nothing wrong with that, but it's really complicated, takes a lot of time, and we want you to visualize very quickly the 3 to 5 steps that are in your process. Now, the 3 to 5 steps may look different from one hospital to another or one ward to another, but it's conceptually what the process looks like for you and what needs to happen. And then within those, identify the defects. Now think of, is there a possible cascade? That is, if we don't do the first step right, it doesn't matter how much we make the other steps more reliable, we have to make the first step right. So let's take an example of what I mean. If we are developing reliable processes for managing a patient with a pressure ulcer, but we don't have a good, reliable process to assess the patient for pressure ulcer risk, then we can develop all those processes, but we don't know how to best to apply it because we haven't identified the patients for whom to apply it. In that case, the flow diagram would point out to you that the first step should be, let's make sure we have a reliable assessment process. You might also identify which is the biggest defect that we need to work on, because if we can fix that defect, maybe we can make the rest of the process much more reliable. And from there you can continue, because you will have to work on the other steps in the process as well. This is an example of a high-level flow diagram. This is a patient who needed to receive a vaccination, and the patient is identified. Again, there's an assessment done that the patient is eligible for the vaccine. The vaccine is prescribed, the vaccine is administered, it is documented, and then it is communicated with primary care, for example. In this case, this team identified that they failed to identify the patient who should be eligible for that vaccine. Therefore, they needed to start there to identify where they can make the process more reliable.
Okay, so back to you, Cara, if you share your presentation so you can have the discussion points up.
Yeah, just 1 moment. Share screen. There we go. Is that visible to everybody?
Yep.
Great. All right. So discussion points from this, the video that you've just seen. So we'd really like some feedback. Please feel free to add to the chat or to talk out loud. When designing a reliable process or system, why does Frank recommend starting with a small test? And have you ever conducted a test and wish you'd made it smaller?
If you don't get it right in your small group, there's a good chance you're not going to get it right in a larger cohort.
That's right. Yeah, excellent. Yeah. All right. And how about thinking about daily processes in your work or school? What population is involved in that process? And if you wanted to make a change, what subset might you start with? Check back up. The answer's to yes.
Robert Crum here. I think that it is interesting to think about which population you should select. I think it depends on the goals or objectives of the quality improvement measure that you're trying to employ. So if you're trying to make things better on the average for everyone, you want to take the population and of patients that is typical and common. If you're trying to prevent an uncommon adverse event, you better select a population that is more similar to those populations that would be likely to have that event. So the characteristics of the population that are being selected for intervention, much like in research, need to be those that are prone to the outcome or the event that you're trying to improve, at least in my opinion.
Yeah, no, that's right, Robert. I think the most important thing related to all these questions is determining what the actual goal is that you want to achieve, and that's often the first place to start. Invite some more comments here. So why are flow diagrams helpful when designing a system, or what other visual tools do you know of that can help with the process improvement? Kim's mentioned on the chat changes to nursing documentation for district, select the representative population, e.g. medical, surgical, ATR to test, and maybe do a small sample in each of these wards and initially go from there. I think that's excellent. Great. I think flow diagrams are important because they allow you to make sure that you've got all of the steps in the process that you're wanting to test and reorder things. It's visual for other people to have a look at and help you with as well.
Yeah, I think that's the key thing, is that it's not one person that has a complete idea of what the system does. You'll find that different people within the system and have different viewpoints and can see things that happen that other people don't see.
Yeah. And another visual tool that you'll see a lot when talking about these things is the use of post-it notes. They're using post-it notes to design your flow chart or flow diagram process where everyone can move things around to make it work.
Just to jump in there, I think that diagramming is really important because there are many magical things that happen in my work where somebody else has done them. I've asked it to be done, and it all of a sudden has been accomplished, and it might take 5 steps, and I don't know that it takes 5 steps unless I diagram it and ask the person that's doing that task to point out the steps that are involved. And so my thinking that it's one thing is actually not necessarily true.
Yeah, that's great. All right, and the last discussion point to think about is, have you ever designed a process or system with reliability in mind? As in like to the test and the retest situation. Any barriers that you encountered, or were you successful, and have you got an example you can share with us? Maybe that's something you can all have a think about in the future.
Yeah, I can share a recent thing that I did. Process mapping for an abscess pathway, just trying to improve the flow of a patient coming through the hospital who had an abscess. And there were things in that system that I wanted to build in reliably. One was the main thing was actually getting patients booked as a day case. And in order to do that, needed to perform a few checks to make sure that the patient was reliable, was suitable for this pathway. So making sure that they're not overtly septic, or that they got diabetes or immunosuppressed, these things which you might in a rush you might forget about asking. So one of the ways was to design a pro forma where it had these things as prompts on it to make sure that people considered these things before putting them on the pathway. And then that form was actually put into the electronic format of the hospital. And on that electronic format, it actually became, those fields were mandatory so that they couldn't actually complete their form without going through these mandatory steps.
Yeah, that's a great example. On the chat under Kim, but from Jen, bedside handover, an example, which is an excellent example of a process or system that's been designed to make sure that when patients are handed over between teams, between nurses at shift, that important information is not being missed. And things that, if you do it at the bedside, it often prompts you to remember other things about the patient that you wanted to hand over. So I think that's a great idea. Excellent.
Cara, I can think of a very basic one that was so simple, it was incredible that none of us had ever thought of it. In the ophthalmology theatre, when we're placing the block, trying to get the patient to look to the side without moving their head. And Nick designed that little stick with the bright coloured card at the end of it, and he'd hold it up in the direction we want the patient's eyes to go. And just something as simple as that made the patients move their eyes rather than their head. And it sounds simple, but it kept the process moving so we can streamline the ophthalmology theatre in another way.
Yes, that's excellent, Angela. That's right. We tried to get patients to look up to a corner of the room, or just to look to the left or to the right, and very easily distracted or hard for them to stick to that. But when they have a big red or orange card to look at, they can do that easily.
That's right. A great example. I'm interested to hear if there were any testing cycles with this card thing, if there was a prototype and there was something not quite right about it and it was changed, like the color or anything. Is there any example there? I
understand there was a testing process. Angie might be able to help me out. I think Nick thought of the idea and discussed it with a few people, then tried it with a few different patients and anaesthetists, and then it was sort of rolled out to the department as an idea.
Yeah, I think so. And because of how simple the idea was, there was a certain amount of skepticism as to how easily it would change the process. So, but people, once they saw it in action, adopted. So I think skepticism was one of the main barriers. Okay.
And were there any other factors around this improvement initiative that sort of overcame the skepticism, other than just showing people? Were other factors in there, like the leadership or data or anything? What else was used to persuade people?
I think that herd, the sheep thing, the herd going along with it. Once you had a few early adopters, it started the cascade of people doing it.
And were there any laggards, and how were they? Because laggards are the people who they're the last people to change, and sometimes the only way to get a laggard to change is to force them, mandate it, or say there will be disciplinary action or something. But I'm sure you wouldn't have done that. But can you think of the laggards and what eventually persuaded the laggard to move over?
I think there's a really real chance of it fading away in the respect that the person that introduced it no longer works there. And unless someone else maintains the initiative, then it could easily, fade away. I have to admit, I've got my first ophthalmology list tomorrow, and I haven't had a list in ophthalmology for, I don't know, a year, 2 years maybe. Right. So I'll be interested to see if it's adopted.
Yeah. And I know that Nick, who did introduce it when there was a laggard or someone who was just unfamiliar with it, and he said, look, let's just try it out. And so he was, promoted it and was very positive about it. Yeah. Okay.
So yeah, I'm just gonna the time is like 7 minutes to
Yeah.
8, so I think we're not going to have time to do the exercise as a group together. But the link is up there for everybody to type that into your browser and download the exercise sheet, and you can do it in your own time, I think. Okay. So any last words, Cara, before we wrap this up?
No, I don't think so. I think it's great to have all these people involved in learning about human factors, about how we're going to improve our healthcare processes and systems and make it safer for ourselves and for our patients. So please, keep up the interest and good work. I'm happy to be involved.
Great. Well, thank you so much, Cara, for giving us your time and giving us an insight into human factors and how it affects you in your daily practice. We'll end the session now, but if anybody has some burning questions, we can hang on for the next 5 minutes and just answer them either through the chat or the voice. Okay, so thanks very much, everybody, for coming.